Hi, I'm Dr. Dawn Koontz, and you're watching Part 1 of the Childhood Anxiety 101 two-part series. As a clinical child psychologist in private practice, I often get referrals for children with anxiety disorders. Specifically, parents wonder whether or not their child's fear or worry is normal, or whether there is something to be more concerned about. If the child's anxiety is determined to be outside the normal limits, parents then wonder about the specific name and symptoms of their child's anxiety disorder and have a myriad of questions related to appropriate treatment of their child's anxiety disorder. In this video, I will provide you with the basic signs and symptoms of anxiety, including normal childhood worries and fears. I will also provide you with information to help you understand the differences among common childhood anxiety disorders. Specifically, the first part of our Childhood Anxiety 101 series is designed to give you an overview of generalized anxiety disorder, obsessive-compulsive disorder, separation anxiety disorder, and specific phobias. Following each brief overview, I will give you information on seeking appropriate treatment. Anxiety can be defined as a heightened emotional and physical reaction to real or perceived threat. Many textbooks refer to this as the fight or flight response. In clinical practice with children and adolescents, I've also noticed a third response of freeze. When the brain scans our environment and perceives a threat, our pituitary glands automatically release a hormone called cortisol, and our adrenal glands secrete adrenaline. The response occurs in a matter of seconds and causes our heart rate to increase, our breathing to quicken, our concentration and focus to narrow, and our bodies to sweat. All people will experience this reaction at some time in their lives, though for most of us the worry and fear do not significantly impair our functioning, and in some cases actually improves our performance. As a parent, I can guarantee that you would not even be watching this video unless you are at least a little worried about your child. So, what is normal anxiety? Most parents can attest to having a child who cried when they were dropped off at daycare, a child who was afraid of storms or the dark, or a child who was afraid that others at school might not like him. These are usually normal types of childhood anxiety. Let's break these normal types of anxiety down by age groups to see if your child has ever experienced any of these. As infants, children usually exhibit anxiety behaviors when they hear loud noises or are around strangers. Stranger anxiety usually develops around 8 months of age and tends to resolve shortly after a child's first birthday. With toddlers, it is normal for them to experience a form of developmentally appropriate separation anxiety from 1 year until about 3.5 years. During this time, toddlers will frequently cry when left with babysitters or dropped off at daycare facilities. Luckily, their tears resolve within a matter of minutes once they realize they are in the hands of caring adults and they can be distracted into fun activities. For preschoolers aged 3 to 6 years, fears consist of trying to handle unfamiliar situations, like going to a new preschool, learning new skills, like learning how to ride a bike or swim, imaginary fears, such as ghosts, monsters, and unknown fears in the dark, fears based on lack of exposure or negative experience, for example, dogs, spiders, snakes, or costumed characters. Elementary school children, 6 to 11-year-olds, typically will experience more real-world fears, such as thunderstorms, burglars, child abduction, tornadoes, earthquakes, fires, injury, drugs, robbers, and dying. Children at this age tend to overestimate the occurrence of these events. What you'll notice is that although all of these things can occur in children's lives, the likelihood of any of them happening and resulting in actual harm to the child is low. During middle school and high school, it is normal for kids to worry about their academic performance, athletic skills and performance, and social acceptance. Now, although I've tagged some of these worries and fears as normal, it is important for parents to realize and understand when their child's fears have developed into something more clinically concerning. Approximately 1 out of 8 children will eventually be diagnosed with some type of anxiety disorder. It is important to recognize that it is not necessarily what the child is worried about, but how intensely he is worrying and whether it is disruptive to his daily life. For example, is the fear causing your child to avoid certain places or things? Is it interfering with your child's sleeping habits? Is it interfering with your child's eating habits? Is it interfering with your child's hygiene routine? Is it interfering with your child's friendships and social activities? Have you noticed that your child can't seem to stop worrying even after being reassured? Is your child repeatedly asking you the same question over and over, even though you have already answered it? Have you noticed an increase in crying, tantrums, irritability, or clinginess? Have you noticed an increase in your child's physical complaints, like headaches or stomach aches? Have you noticed an increase in your child's negative remarks about himself or others? Are you changing your own routines or family activities to accommodate your child's fears? If you answered yes to one or more of these questions, it would make sense for you to talk with your child's pediatrician about the possibility of an anxiety disorder and have your pediatrician rule out any underlying medical conditions that can create similar physiological and emotional responses. If there is no underlying medical condition and your pediatrician agrees that your child should seek evaluation and treatment for anxiety, ask your pediatrician for a referral to a good local child psychologist. If medication is deemed necessary, your pediatrician will either manage the medications him or herself or refer you to a board-certified child psychiatrist. Ongoing treatment will be a collaborative effort between you, your child, and your child's healthcare providers. In order to determine the best treatment for your child, a child psychologist will usually do some type of assessment or evaluation to determine both the type of anxiety disorder and the severity of the disorder. The psychologist will also try to rule out other disorders that may mimic the symptoms of anxiety. In addition to diagnostic and clinical interviews with you and your child, an assessment will also include symptom-based self-report measures for your child to complete, parent report measures, and often teacher ratings of the symptoms as well. Once the assessment is complete, your psychologist will discuss your child's clinical diagnosis and give you information about treatment options. Treatment, of course, is based on the appropriate diagnosis. Within the realm of anxiety disorders, children and adolescents can be diagnosed with one or more of the following: generalized anxiety disorder, or GAD, obsessive-compulsive disorder, or OCD, separation anxiety disorder, panic disorder, social phobia or social anxiety disorder, selective mutism, specific phobia, post-traumatic stress disorder, or PTSD, or acute stress disorder. In Part 1 of our Childhood Anxiety 101 series, we'll only be covering generalized anxiety disorder, obsessive-compulsive disorder, separation anxiety disorder, and specific phobias. Following the review of symptoms for each disorder, I will also touch briefly on evidence-based or scientifically backed treatment options for each disorder. If you are interested in overviews of panic disorder, social anxiety disorder, selective mutism, post-traumatic stress disorder, or acute stress disorder, please check out our video, Childhood Anxiety 101, Part 2. Let's start with generalized anxiety disorder. Children with generalized anxiety disorder tend to be chronic worriers. By chronic, we mean that they have been worrying longer than 6 months. Children with generalized anxiety disorder worry excessively and persistently about a variety of things, including, but not limited to, their academics, friendships, family relationships, athletic performance, current news events, and general world issues such as climate change or world hunger. Children and adolescents with generalized anxiety disorder tend to be high achievers, people pleasers, and perfectionists, even though they always seem to expect the worst. Often their worry is exaggerated and unrealistic given the set of circumstances. They are also very sensitive to even the slightest criticism from others and tend to hold very high expectations for themselves. They worry so much that it interferes with school, family, and social activities. Other symptoms that may accompany generalized anxiety disorder include things like stomach aches, headaches, nausea, diarrhea, agitation, tearfulness, difficulty sleeping, difficulty eating, and restlessness. Like all anxiety disorders, research has shown that there are 3 basic options available for the effective treatment of generalized anxiety disorder. Children and adolescents with generalized anxiety disorder tend to have inaccurate or distorted perceptions about things that end up causing them a great deal of unnecessary worry. For example, a child with generalized anxiety disorder may worry about not having friends or making bad grades, even though there is evidence that they indeed have friends and make good grades. These inaccurate perceptions are called cognitive distortions. The most effective treatment for dealing with these cognitive distortions is cognitive behavioral therapy, or CBT. Cognitive behavioral therapy uses a process of systematically challenging and changing the thoughts and behaviors that are maintaining the child's anxiety. Another treatment option is medication, usually in the form of a class of medication called SSRIs, which stands for Selective Serotonin Reuptake Inhibitors. These medications, which are often used to treat depression, have also been found to be quite effective in treating anxiety as well. Yet a third option is a combination of medication plus CBT. The most effective and efficient treatment is the combination treatment, but either medication alone or cognitive behavioral therapy alone will also relieve many of the symptoms. When deciding which of these treatment options is best for your child, parents should be aware that the current research shows that although it is effective, it takes longer for cognitive behavioral therapy alone to decrease anxiety. Further, medication is strongly recommended if the anxiety symptoms are considered moderate or severe in their range of intensity and impairment. The next anxiety disorder I'll discuss is obsessive-compulsive disorder, or OCD. Children with OCD are typically identified once they are in elementary school, though some can be identified as early as preschool. The defining characteristics of OCD are unwanted intrusive thoughts, which we will call obsessions, coupled with some type of ritual or routine, a compulsion, that is designed to reduce the anxiety associated with the obsession. Some examples of obsessions might be germs, contamination, order, symmetry, negative or aggressive impulses, fearing that they may harm themselves or others, concern about accidentally harming someone through an unintentional act, or being afraid of throwing something away that they may need in the future. To combat the obsessions, the compulsions may include washing or cleaning, checking something multiple times, repeating a word, phrase, or activity, touching and rearranging things, engaging in mental rituals, or hoarding items. When the compulsions are restricted or interrupted, children and adolescents can become irritable, tearful, begging and clinging, repeatedly seeking reassurance that they and/or others will be okay if they do not engage in their compulsion. Without proper treatment, some children and adolescents may even become violent if they are prevented from engaging in their compulsion. Children and adolescents with OCD vary widely with their presentation of symptoms and severity of symptoms. However, in order to make a diagnosis, it must be clear that the obsession and/or compulsions are interfering with the child's daily functioning at home, school, or socially. If your child has OCD, it is imperative that the psychologist you choose to work with your child has expertise in treating OCD and other anxiety disorders. During the first phase of cognitive behavioral therapy for OCD, children are taught relaxation skills, such as deep breathing and progressive muscle relaxation, so that they can engage in the use of these relaxation strategies to alleviate some of their physical symptoms of anxiety while participating in treatment, which in itself can evoke feelings of anxiety. Progressive muscle relaxation typically involves trying to get the child to systematically tense and then release the muscles of the body from head to toe. There are a number of scripts that parents and therapists can use for this part of treatment. The next phase of treatment involves having the child create an anxiety hierarchy from the least feared situation to the most feared situation for what is called exposure and response prevention. In the exposure and response prevention phase of treatment, children are gradually exposed to their feared thought or situation, let's say germs in this case, based on their self-created hierarchy, while they are prevented from engaging in their typical compulsion, say washing their hands or taking a shower. Simultaneously, children are taught how to cope with the cognitive distortions that have been maintaining their OCD and substitute those thoughts for more accurate and healthy thoughts. Although cognitive behavioral therapy alone works well, research has shown that the very best treatment for OCD is a combination of medication and cognitive behavioral therapy. Another anxiety disorder is separation anxiety disorder. Because separation anxiety is also part of normal development, the clinical presentation of this disorder is often initially harder for parents to identify. Babies can distinguish between their parents' faces and faces of others as early as 3 months. Around 9 months, babies start to cry when left with other caregivers, whom they categorize as strangers. This usually peaks around 12 months and then subsides by 18 months, although some children can experience this intense sadness of being separated until they are around 3 years old. Most parents can attest to this stage of development, where it is quite common for children to cry when left in new situations, such as a daycare or preschool. The crying usually stops after a few minutes with some fun distractions to engage them by the caregiver. Eventually, most children are able to adjust to this change after a few drop-offs and may even look forward to going into the new environment. Clinically, true separation anxiety disorder occurs in approximately 4% of children. Most often, children with separation anxiety present to therapy when they are between 6 and 10 years old. Children with separation anxiety typically verbalize fears that if they are separated from a loved one, harm or even death may befall the loved one. Some children are even afraid that their parents will not return, despite this never actually occurring. Children with separation anxiety disorder may be so fearful that they cannot be alone in any room of the house or sleep in their own bed. When they do go to sleep, some of these children have nightmares with the theme of abrupt separation from their loved ones. In extreme cases, children may even refuse to go to school, camp, birthday parties, or play dates for fear of being separated. Physically, they may complain about headaches, stomach aches, and nausea. Emotionally, they are prone to clinginess, crying, and tantrums. Again, a CBT model of psychotherapy that includes gradual exposures to brief separations is a vital component of treatment. Additionally, it is important to make sure that the child understands what will be happening in the treatment process. Parents, children, and school personnel should all receive information at each phase of treatment so that all parties understand and are consistent with treatment recommendations. Treatment should also include relaxation training, challenging cognitive distortions, and positive reinforcement for successful separations. Parents of children with extreme separation anxiety should also consider consulting with their pediatrician or a psychiatrist about medication management of the disorder. Most physicians will start with a medication from the SSRI family if medication is indicated. We're all afraid of something, right? Well, the next topic I'm going to cover is specific phobias. Most people can relate to this one, whether it's their fear of flying, fear of dogs, fear of storms, fear of snakes, fear of mice, fear of spiders, or fear of public speaking. So we kind of know what it's like for our children. The only difference is that most adults can recognize this intense fear as irrational, whereas children may think that their fear is perfectly rational. Common childhood phobias include the fear of storms, dogs, snakes, spiders, heights, water, fire, blood, the dark, needles, and medical procedures. Depending upon the type of phobia, children will either try to avoid the feared thing or situation or endure them with intense anxiety. The anxiety manifests in repetitive questions, clinginess, crying, tantrums, and avoidance. Physical symptoms also include headaches and stomach aches. The gold standard for treating specific phobias is a technique called systematic desensitization. During this process, a child is very gradually exposed to the feared stimulus and given positive reinforcement as each new level of exposure is successfully reached. As an example, a child afraid of dogs might initially be exposed to books and pictures about dogs, then have to look at a live dog through a window, then look at a live dog walking across the street, then at a dog in a cage beside them, then look at a dog on a leash beside them, and finally to touch the dog. Some children may even need a few additional steps in between to make the process more gradual. Additionally, the child is taught how to use relaxation techniques, positive coping statements, and how to challenge cognitive mistakes in their thinking. In summary, fear is a natural part of the human experience, and every child will have worries and fears. However, it is important for parents to realize and acknowledge when a child's fears transition from the normal range into the clinically significant or abnormal range. It is at this point that your child may need intervention by an expert. To make the process easier for you, we encourage you to check out our free videos on choosing a child psychologist and paying for psychological services, especially if you've never been through the process of finding your child a therapist. Once you have found someone to treat your child, make sure that they are familiar with proper assessment to accurately determine which anxiety disorder is being targeted for treatment. You will also want to make sure that they use evidence-based or scientifically backed treatment strategies. In the case of anxiety disorders, cognitive behavioral therapies have the most research backing treatment success. Cognitive behavioral therapy should include some form of relaxation training, teaching children how to change their negative and anxiety-provoking thoughts into more accurate perceptions and healthy thoughts, and having children gradually face their fears while using those new relaxation and thought-changing skills. Additionally, if therapy alone is not alleviating your child's anxiety, it will be important for you to seek a medication evaluation from your pediatrician or child psychiatrist to ascertain whether your child might benefit even more with medication in addition to therapy. Once on medication, many children are able to quickly grasp the techniques and strategies necessary to cope with their anxieties on their own, thereby eliminating the need for long-term use of medication. Children with anxiety disorders often wax and wane in their presentation of symptoms. Parents may find that their children's symptoms get worse with increased stress, trauma, puberty, or even growth spurts. When you see these flare-ups, encourage your child to talk with you and engage the coping strategies that he or she learned in therapy. We hope you have enjoyed this video on Childhood Anxiety 101, Part 1. If you are interested in information about other childhood disorders or positive parenting techniques, check out our video library. If you are looking for something specific and don't see it, fill out the Suggest a Topic section on our website. At mychildpsychologist.com, we want to work with families to provide relevant, up-to-date, and affordable information on the topics parents are most interested in. Well-informed parents make the best parents of all. Thank you.